Welcome to this series of videos on communicating with chronic pain patients. This is Module 2, Building Trust in the First 5 Minutes. Imagine you're seeing a patient with chronic low back pain for the first time. Before you walk into the room, you review their chart. They've had pain for 8 years. They've seen 3 physical therapists, 2 orthopedic surgeons, a chiropractor, and a pain management physician. They've had injections, medications, MRIs, and several rounds of therapy. And now they're sitting in front of you. You might be thinking, how am I going to help this person? But the patient may be thinking something very different. Is this person actually going to listen to me? That's why the first goal of the encounter may not be education. It may not be diagnosis. It may not even be treatment. Your first goal may simply be to establish trust. We sometimes think of the therapeutic relationship as something that surrounds healthcare. There's the real treatment, exercise, medication, education, procedures. And then there's the relationship we have with the patient. But research suggests that distinction may be a mistake. A 2026 systematic review examined 37 studies involving more than 10,000 patients with chronic non-cancer pain. Researchers looked at factors including therapeutic alliance, empathy, trust, and patient-clinician interaction. Across most of the studies, better patient-clinician relationships were associated with better pain-related outcomes. In other words, the relationship isn't simply how we deliver the treatment. The relationship may be part of the treatment, and that relationship begins almost immediately. Think about the first minute of a typical healthcare encounter. We introduce ourselves, we sit down, we open the computer, and then we start firing questions. When did your pain start? Where does it hurt? What makes it worse? What treatments have you tried? Those are important questions, but there's a danger. The patient can quickly feel like they're being interrogated instead of heard. Try starting differently. After introducing yourself, give the patient an opportunity to tell their story. You might say, "You've been dealing with this for quite a while. Tell me what this experience has been like for you." And then do something surprisingly difficult. Stop talking. Listen. Don't immediately correct them. Don't educate them. Don't tell them what you think is causing their pain. Let them tell you their story. While they're talking, don't just listen for clinical information. Listen for emotion. A patient might say, "I've been to 5 different doctors and nobody can figure this out." The biomedical information is, they've seen 5 doctors. But the emotional information might be, "I'm frustrated, I'm scared," or "I'm losing hope." That's where empathy comes in. Instead of immediately responding, "Well, let me take a look at your MRI." Try, "That sounds incredibly frustrating. You've put a lot of effort into trying to get better." Notice what you haven't done. You haven't agreed with everything the patient believes. You haven't promised that you're going to fix them. You've simply demonstrated that you understand something about their experience. That matters. Evidence reviews of communication in chronic pain consistently identify feeling believed and validated as important to effective patient-provider interactions. Here's another common mistake. The patient says, "My doctor told me my back is bone on bone," and immediately our healthcare provider brain kicks in. We think, "That's not how pain works. I need to correct this." So we jump in. Well, actually, those changes on your MRI are common in people your age, and imaging doesn't correlate very well with pain. Maybe that's scientifically accurate, but it might be the wrong thing to say at that moment. Why? Because before the patient hears your explanation, they need to trust the person giving it. Instead, get curious. Ask, "When you heard that your back was bone on bone, what did you think that meant?" The patient might say, "I thought it meant my spine was wearing away, and eventually I wouldn't be able to walk." Now you've discovered something incredibly important. The problem isn't simply the MRI finding. The problem is what that finding means to the patient. And now you have something meaningful to discuss. There's another question I think every healthcare provider treating chronic pain should consider asking early in the encounter. If we could make progress together, what would you most like to get back to doing? Maybe the answer is, "I want to pick up my granddaughter. I want to get back on my bike. I want to work without thinking about my back all day." Now the conversation changes. We're no longer just talking about a pain score. We're talking about the patient's life, and we're beginning to establish one of the foundations of a therapeutic alliance, a shared goal. Instead of, my goal is to reduce your pain from a 7 to a 3, it becomes, our goal is to help you get back to riding your bike. That's a very different relationship. Finally, communicate that you're going to work with the patient rather than simply do something to them. You might say, you've been dealing with this much longer than I've known you. You know your experience better than anyone. I have expertise that I hope can help, so let's put those two things together and figure out a plan. Think about the message that sends. I'm not dismissing what you've experienced. I'm not claiming to have all the answers. And I'm not making you responsible for figuring this out alone. We're working on this together. That's partnership. And partnership builds trust. So what should happen during those first 5 minutes? You don't need a complicated communication technique. Remember 5 things. Listen. Give the patient space to tell their story. Validate. Acknowledge what they've been through. Get curious. Before correcting beliefs, understand where those beliefs came from. Find their goal. Discover what pain is preventing them from doing that actually matters to them. And finally, create partnership. Make it clear that treatment is something you're going to work on together. Because a patient with chronic pain may not remember every explanation you give them. They may not remember every exercise you prescribe. But they will probably remember whether they felt believed. They'll remember whether you listened. And they'll remember whether they felt like you were on their side. Before you can influence someone's beliefs about pain, you first need enough trust for them to listen to yours. And building that trust begins in the first 5 minutes.